small outstanding errors. It didn't show a difference. FDA conclusion, no change. But as clinicians, you need to understand, for me, the pulmonary embolism is the main one. The other three is something easy to monitor. Pulmonary embolism is hard to monitor until someone shows up at your doorstep. So this is your counseling you have to do. Okay? So this was the conclusion. Modest increase in non-MACE adverse events. Clinical significance, not very clear. So further ongoing analysis in progress. This came out in 2024. Okay, so very new. Okay. Do we have time? Because this one is not so important. Do we have time? Okay, short version. The reason that all is bad news, 2 studies came out in 2013 and 2014, which the advocacy group said directly showed testosterone causing heart attacks. 2013, 2014. After the studies came out, Endocrine Society jumped in and said, testosterone bad, you get heart attacks. The Wigan study, 2013, right? They looked at men who had low testosterone levels and who had got a testosterone prescription. Whether they took it, didn't take it, whether they had a heart attack, nobody knows before the study. After the study, they followed up. And the interesting thing about this study, the first screw up is 10% of the people in the study were women. Okay, it's supposed to be a men's study, but 10% of people included in the study were women. Right? Yeah, I know, they screwed up. This is the raw data. So if you look at the raw data, the testosterone group actually did better. The problem is when they finish the analysis, so if you look at the raw data, testosterone group did well. At the end of the statistical analysis, they said testosterone did worse. So there have been a lot of complaints about this study. It's still not retracted. If you go to the website where it's published, you can see all the corrections. The FDA removed the credibility for this study, but the effects of this study and this one is why till today testosterone therapy has a black box warning. The FDA has not removed black box warning from testosterone therapy. Why is black box warning important? What is a black box warning? It tells you of a major event with the drug you're using and that you have to tell the patient about that warning. So even though all new data doesn't show anything, the black box, as far as I know, has not been removed from the FDA website. So notice everybody Googles this stuff. So if anybody types in Google testosterone therapy, they're going to come to the black box warning. And same like the screw up with the Women's Health Initiative, headlines. So this is actually a supplement company, what is it called? Life Extension, among other newspapers. Headline is, testosterone therapy causes heart attacks. And we've never really recovered from these headlines. But your patients are going to find these headlines. And you need to be able to explain these headlines. Okay? So we are still, they're saying even though the FDA has said it is difficult to attribute any heart attacks to these 2 studies, there's no increased risk, they still have not removed the black box warning and the studies have not been retracted. Okay. I'm going to skip this one. Okay. Short, quick one. I know this is actually, I had more to talk on this, but anyway. So what is available to you? You have bioidentical gels, injections, right? That's what we have in this country. Anyone got anything else? No, right, 3 only. We don't have oral here yet. We do, but not a very good one. In the US, there is an interesting oral one. Okay. Now, testosterone is released daily. The skin acts as a depot. That means when you rub it in, it goes into the skin and it releases slowly over 24 hours, right? Absorption, 20-30%. Once a day, painless. The gel and the cream, the gel is androgel, alcohol based, right? 50 milligram fixed dose. The cream is the one that is adjustable. So I'm not doing a very good job of this. Let me go one by one again, sorry. Let's start with the cream. As I told you earlier, The creams allow customized dosing. Okay, it absorbs pretty well on a damp skin. It's fairly easy to use, and actually pricing wise is slightly cheaper than a standard gel. Topical, okay, twice daily, once a day, what dose you use, you will adjust to the patient, right? Usually for me, I start once a day, depending on the patient, see how they're doing, look at their symptoms, and then adjust it from there. Either go up, go down, increase the frequency, very customizable to the patient. There are no 2 hours who are alike. On average, I find that once a day seems to work quite well. Dosing standard, you can start, somebody asked me this question earlier, so when do I start? I start about 100 milligrams once a day, and then you adjust it, right? In some patients where the hematocrit is skyrocketing, for whatever reason, I may give them a hormone holiday. I mean, I give them 5 days on, 2 days off, or something like that. You have to, this is something you're going to discuss with the patient and adjust. Now, the biggest 2 problems with cream: patient compliance, you have to make sure they do it properly. Number 2, product quality. Now, there's no law that says who uses what, or how they manufacture, or where the licensing is. I'm sure all of you have your list. I already told you how I do it, so I tend to go for the BMW version. Okay, like I said, having patients who are see, the problem with using sub-quality products is, if your patient is not happy, they tend to blame you. At least my experience, my patients blame me. They don't blame the product. And it can get painful because patient said, I paid this much, I got this, and now I feel worse. Very, very hard to answer. Do you all have similar experience or no? No. Patients blame you all, right? Yeah. So, and I end up wasting a lot of time discussing this. So I don't know whether it's a good reason to use the BMW product, but my logic is I don't get blamed so much and I don't have to spend endless hours on a discussion. The gel is a very stable product, comes in individual sachets, quite freely available. It's a little bit more expensive than the cream. Some Muslim patients don't want it because it's alcohol based and it's not a mandatory drug. I mean, it's not something they have to use. If it's a mandatory drug, we have permission to use even if it's not halal. But if it's not mandatory drug, then you have to look at options. So I have some patients who flat do not want to use anything alcohol based, so it's a choice, it's fine. Some patients, I'm one of those, I get skin irritation with alcohol. So when I rub it on the shoulder, after 2 or 3 days, I get like a rash, like a burning rash. So that's something to be aware of. But other than that, works quite well, absorbs standard dose, so you can't adjust the dose. Injectables, the only one we have in Malaysia currently is Nebido. I already told you, once in 10 weeks, good for disabled patients, elderly, home care patients, patients with poor compliance, poor support. Would I use it for a healthy 50 plus guy? No. You literally will yo-yo. And when you're on the peak, right, it is very, very hard as a guy to tell you to think straight. Seriously, it is very hard because I've seen my testosterone level go up to 40 and 50. So normally it's 35. I function with 50, trust me, not fun. Your mind is all over the place. Not in a fun way. Okay? Main problem, yo-yo, you have a peak, flattens out, drops, and then you peak again. So a patient is going through this like a sine curve. All right. So we have covered mechanism, we have covered control, low testosterone, key papers, complications, benefits. Right? Okay. Right. Am I missing anything? By the way, I'm open to correction or anything. I'm good. Just tell me if I made a mistake or something. Really? No one want to ask me anything? Hey, no, please, no. Okay, so women, you are less than 10%. Okay, your requirement is under 10%. I think Christina will answer this. I use 2.5 to 1.25. It depends what I'm trying to achieve. Now, I sometimes mix it with estrogen cream. You mix it? Okay, so Okay, so she's right. Oral estrogen actually works better. Okay, I work in a hospital. So at which point I get 10 phone calls telling, you have given oral estrogen to my patient, you're going to get DVT. She's right, by the way, Christina is right. I fully agree with her. I tend to be lazy sometimes. So like, patient goes see the cardiologist, see here, see there. Okay, never mind, you use transdermal. You're happy, I'm happy, I don't have to fight with you. For patients who are well-educated, who are willing to listen, I fully agree on oral estrogen. The evidence is there. But sometimes you just cannot argue with your colleagues and you cannot argue with the patient. So you're like, okay, you want cream, take cream. So when I use transdermal, I mix the estrogen with testosterone. Clitoral hypertrophy is a little bit of a problem. And sometimes you get interesting, okay, I don't know whether it's a complaint or not. So had one woman who's 60 who came and told me, look, I sleep at night, I orgasm automatically. I don't like it. Can I put the cream on my arm? Fine. Okay. Some women like it, some don't. So I 2.5 milligram, 1.25 milligram, mix it with estrogen. Depending, I mostly use E2. There are some reasons I use E3, but mostly it's E2. Okay. 2.5, 1.25. Do you use a different dose? So slight high dose. I so far have no downside. You are not going to get hairy. You are not going to develop muscles like Schwarzenegger. Most you may tone up a bit. I've never seen a woman actually bulk that much. Very, very difficult. But it's a phobia. Trust me, it's a phobia. They all come to me, am I going to get big muscles? No. If you could get big muscles that easily, I'll have big muscles. Okay? Right. Next question. Oh, okay, fine. So they're telling me to get lost. Right. Okay. Okay, if I made a mistake somewhere, please correct me. I do make mistakes very often, in fact. You can email me, WhatsApp me, and I'll get back to you eventually. The slides are available. You can get it. Any questions, feel free. All right? Okay. The graph starts at about 6 months. Okay? It goes to about 18 months, and then it starts to flatten out by the time you're about 2 years, it starts to flatten out. This is your average person who basically has not changed lifestyle. Okay? Compared to my bodybuilder patients, they are committed, dedicated. They can pump iron, they can put on 4 to 5 kilos of muscle in a week. They are really committed. Your average patient will be lucky if you get 4 to 5 kilos in 2 years. That is, if you just basically continue your life, maybe you go to gym a little bit, you swim a little bit, you jog a little bit, reasonably, 4 to 5 kilos. Okay? Not your size, by the way. Okay, but my size. Your size, which are 4 to 5 kilos muscle. Yeah. Okay? Anyone else?
All right. I think we will save the rest of the questions for the panel later as we prepare to set up. And thank you, Doctor. Let's give a hand to Dr. Muhilan. Yeah, while we are setting up, you have some feedback forms on your table. Can you please help to fill it in? Thank you very much.